of a physician or a surgeon is competency based. Your skill and knowledge will give you recognition. It's not only planning, rather both planning and execution, both are important to create your identity. Even Association of Cardiologists could not sustain on simple prescription only. Now, interventional cardiology is progressing like anything. Time has come for us also to think about interventional physiatry. Musculoskeletal ultrasound plays a pivotal role in interventional physiatry. Today's webinar is on musculoskeletal ultrasound fundamentals, which will certainly beneficial for the beginners and also the refresh the knowledge of the seniors. So, for presentation of today's topic, we have with us one of the senior member of our association, and a known physiatrist, interventional physiatrist. He is none other than Dr. Kumar. He is additional professor and head of the department, rather founder head of the department of PMR, IGIMS, Patna. He has done his post-graduation from AIMS New Delhi in PMR, and he has done also fellow in pain medicine. Currently, he is EC member of IAPMR, also secretary of Bihar Association of PMR, and also joint secretary Academy of Pain Physiatrist. His academic interest is revealed by his publications, like he has more than 10 number of publications as first author, and he has written book chapters in international books, chapters like botulinum toxin injection techniques in cerebral palsy. Also, his academic interest is glorified by his contribution of 2 chapters to our IAPMR textbook. One is on diagnostic ultrasound in PMR, and second chapter is administration in PMR. He has been resource faculty for many pain and ultrasound workshops. He has special interest in interventional physiatrists. Without much wasting time, I invite Dr. Kumar to speak on his topic, that is musculoskeletal ultrasound fundamentals. Over to Dr. Kumar.
Thank you, sir. In fact, thank you very, very much, sir, for the kind introduction. And I'm thankful to you and Odisha chapter for giving me opportunity to speak about the role of musculoskeletal ultrasound in this national platform. So my esteemed colleague, teachers, postgraduate students, this webinar is aimed to give a practical idea actually for doing or starting musculoskeletal ultrasound in one's daily practice. We will not go into the theoretical intricate details in this presentation. And through that, we will try so that we can add precision as well as delivery of any kind of regenerative or intervention thing as or whenever required. And we know that mastering the fundamentals is very, very crucial for precision of the diagnosis and effective interventional rehab treatment. So in this webinar, like various protocols will not be discussed, which are commonly done for like shoulder, elbow, or nerve, or joint. Any detailed protocol is not going to be discussed here. Okay. And in this 30 or 40 minutes webinar, we'll try to integrate the musculoskeletal ultrasound with my practical experience. With my practical experience, that is of almost 15 years of practical experience. So I am sure many experts will also be listening to this webinar, and they will add important basics, whichever I will miss due to time constraint or due to lack of my knowledge. So this will be my overview of the presentation. We'll start with the basics of the USG, image interpretation, various muscular characteristics, pathologies, and clinical implication, and finally I will summarize. So it's very clear that within half or 1 hour lecture, one cannot become expert in musculoskeletal ultrasound. It requires a lot of practice, lot of dedication. Okay. So let's start with the basic technical consideration. This is the ultrasound machine which I am using. Okay. And these are the three probes. This is linear probe, this is curvilinear probe, and this is hockey stick probe. Nowadays, various kind of machines are available. This one I have seen most of the places, portable kind of ultrasound machine is there. So how this sound wave acts? You know, in sound waves, in transducer, there is with electric current, piezoelectric effect is produced, and that goes to the various part of body organ, and accordingly, whether how they absorb, how their acoustic impedance, they will reflect it back. And this transducer also act as a receiver, which will, and they produce image which will see in our screen. And if we see this is a say 10 megahertz linear probe, and this is 2 to 5 megahertz curvilinear probe. So it has, we can see it has deeper penetration, and we can see this linear transducer has superficial penetration. So with this superficial penetration, we can see these 2 points can be better visualized. We are able to delineate these 2 points. So superficial structure has good resolution. But with this low frequency that has longer duration probe, this 2 superficial point is not clearly visualized. So we cannot able to find out the detailed structure, what is going on in between 2 points, because it's here we can see these both points are close together. So with ultrasound machine, basic, we have the power button through which we can off or on the machine. We have various kind of probe I discussed, and basic 3 things to, like, we have to decide what should be depth of that structure, and what structure we are looking for, where is our focus, and gain. We can increase overall brightness or of that image, or TGC in some machine, like superficial structure or deep structure can be better visualized with this adjustment in time gain compensation. And whatever we can see here, this is the focus of the point. We have kept focus here, then only we have able to visualize this posterior branch of obturator nerve. Here, focus is here, so we are not very well able to visualize this posterior branch of obturator nerve. So we have to keep the depth and focus accordingly. It's very important in initial practice. So why must we should use musculoskeletal ultrasound? I think we should see this slide at the last when we finish. So we know that there is one famous dialogue in in a Hindi film कि फिल्म को हिट होने के लिए क्या जरूरत होती है. तो डायलॉग है कि 3 चीजों की जरूरत होती है, इंटरटेनमेंट, इंटरटेनमेंट एंड इंटरटेनमेंट. उसी तरीके से मस्कुलोस्केलेटल अल्ट्रासाउंड के लिए 3 चीजों की जरूरत होती है, एनाटॉमी, एनाटॉमी एंड एनाटॉमी. And we know it's an extension of clinical examination. So when we combine with this anatomical background, our clinical acumen, and with practice, that we call it CAP. Okay, clinical examination, anatomy, and practice. If we wear this cap now, we'll able to solve the most of the problems of the musculoskeletal medicine, I think, with some sort of limitation, which we'll be discussing later. So let's see how fluid detects. Fluid, since there is no sound travels very easily with the fluid, so fluid looks anechoic, which is black. Okay, this 60-year patient of a breast carcinoma comes with me, referred by an oncologist for shoulder pain. When we examine, there is no problem in the shoulder pain, but when we examine, we thought this area is anterior chest area is looks swollen. This is the ultrasound picture. About 150 ml of fluid were aspirated. This is the needle. 150 ml, and after aspiration, we can see all fluid has gone. So fluid looks black, and this is the most basic common things we all should understand, whether any kind of serous fluid or joint fluid, anything, etc. And this is, we can see this hypoechoic area. This is the gastrocnemius muscle and this is the soleus muscle. So this is the collection of blood in soleus muscle in case of hemophilic arthropathy in a 23-year-old male child. Okay, let's start how ultrasound muscle looks in the ultrasound. So we should understand the basic structure of the muscle. These red colors are the muscle, okay, and which is lined by the endomysium. And again, this we can see this collection of this all muscle fiber is lined by the perimysium. And again, group of this all muscle bundle covered by the epimysium. So this all lead color muscle will look black, that means hypoechoic. And all these things, this epimysium, perimysium, okay, this endomysium will look white, that is hyperechoic. So how muscle will look? It will depends on the structure of the muscle. Okay, muscle may be in the parallel form. If it is in the parallel form, we will see it is in parallel. Okay, so whatever type of the muscle is there, we'll able to, like if we'll keep probe our hair in this parallel muscle, so we'll see ultrasound picture, there will be the fibers will look like this parallel structure. Okay, so in theoretically it is called in cross section we'll see muscle, it will look like a starry night or a starry sky appearance, or in longitudinal section it will look like parallel, or we can say vein of a leaf like appearance. So we can see here, this is the gastrocnemius muscle. We can see these are the parallel fibers. We can see white parallel fibers of this muscle. Okay, and we can also see at even isometric contraction of the muscle, this pennate angle is increased. Okay, so small tears, like elongated type of tears, may be we'll able to find on this contraction of the muscle and evaluation by the ultrasound. Okay. So what are the pathologies we may encounter in the muscle? We'll able to find out muscle atrophy. We'll able to find out the muscle atrophy, or like pseudomuscle atrophy. In pseudomuscle atrophy, muscle is replaced by the fat. So muscle means that all hypoechoic structure is lost and fibrous structure is gaining more prominence. So muscle structure will be more hyperechoic. It will look more whitish. Okay, and muscle rupture, various kind of muscle rupture we can able to evaluate. All kind of grade 1 to grade 2 to grade 3 tier we can able to find out. Muscle hernia, we'll see how muscle hernia can able to diagnose. We'll able to diagnose any kind of muscle tear also, or any muscle injury, but they have different protocols so that we may not miss that kind of injury. But mild contusion and delayed onset muscle soreness, we may miss those kind of things in musculoskeletal ultrasound also. So here we can see this is deltoid muscle. This is starry sky appearance. We can see this is starry sky appearance in this ultrasound muscle. This is biceps tendon. In cross section, muscle look starry sky night appearance. And this is the deltoid muscle. Here we can see this parallel kind of things. We can see deltoid appreciated in the deltoid muscle. So this is the longitudinal axis. We can see here say in longitudinal axis and in transverse axis how muscle may look like. Okay, and here we can see muscle is the total tear of the biceps muscle. So all biceps muscle is retracted here and looks white, hyperechoic. So this is retracted fibrous muscle of the biceps. This is in the longitudinal section and this is in the cross section at the mid-arm. Okay. And here we can see this is the cross. If we keep our probe here in anterior thigh, we will see this structure. This is the rectus femoris. This is the vastus intermedius. And here at the same point here, we can see this muscle is draw. We are just a small area we can able to see the muscle. So this is the total tear of the rectus femoris. Here we can visualize this. And here we can see this is the rectus femoris, this is the vastus intermedius, and this is the collection of fluid. So here it is the tear of the vastus intermedius muscle. Okay. And here we can see this is the normal fibers of the medial head of the gastrocnemius. And here we can see there is disruption of the fiber and this collection of this small hypoechoic area. So this small hypoechoic area represent tear in this case. Okay. And here also in transverse section, these are both lateral and medial head of the gastrocnemius. And here we can see this is the normal picture and this is the abnormal picture. Here we can see this hypoechoic area represent tear. So we can easily find out the tear. And in muscles, sometimes some small hypoechoic area may be seen, which is usually not found in the muscle. And this hypoechoic area, this is the flexor carpi ulnaris muscle. And within this bright structure, this white structure, this is the scolex of hydrated cyst. So this patient was represented with the like partial claw hand. And when we scan the forearm of the muscle, we found there is collection in the flexor carpi ulnaris muscle. And here we can see on this patient comes with the anterior leg pain while walking. Here we can easily able to see this small elevated area. When we kept our probe here, we can see there is clear-cut gap in this fossa. This is the gap in the fossa through which muscle herniated. So this small muscle, even a small muscle herniation can also be able to diagnose with this. Coming to the tendon, again, let's see the basic structure of the tendon. We all know the basic structure of the tendons, and tendon looks like fibrillar, total fibrillar, compact white structure, parallel white structure. Tendon looks like this. Here it is black because here ultrasound ray is not perpendicular to that tendon. So it looks black. This is anisotropic. Beginners usually confuse it as a tear, but with practice, they are able to utilize this property in diagnosing various type of pathologies. And in cross section, this tendon looks like broom in appearance. झाड़ू के पीछे वाला की तरह दिखता है बिल्कुल. Dot fibers. Here in cross section, this way. These are the tendons. So these are the basic characteristics of tendon, how it looks like. So this all we should know. What is anisotropy? It is the property of especially any tissue like tendon, nerves, or muscle that display different ultrasound appearance depending on the angle of insonation of the incident ultrasound wave. So this is the most common artifact we see in musculoskeletal ultrasound. There are other artifacts also we will come to later. So here we can see this is the normal tendon, and here when rays are not perpendicular, we can see hypoechoic structure. So this is due to anisotropy. This is not tear. This is the structure of the tendoachilles, and this is when we are not perpendicular to the tendoachilles. Looks black. So this is not tear. And another artifact is post-acoustic shadowing. So whenever like any calcification or any other things comes in the path of ultrasound, it reflected back. So below this section, nothing, we are not able to visualize anything. Ultrasound cannot able to pass down. So it makes acoustic shadow here. And here in this picture, we can see this is the path of the needle. This is the here needle is coming. And we are injecting methylprednisolone, and the like crystals of methylprednisolone making this picture, okay, like calcification. Okay. And this is reverberation artifact. We can see multiple parallel lines along with the needle. So these are reverberation artifact, because when ultrasound hit the needle, it continue back and forth, back and forth, back and forth, creating multiple images. So this is reverberation artifact. And this is, we can see probe is kept like this in transverse processes. And here we can see post-acoustic shadowing due to transverse processes. This is trident sign. Okay. And coming to the tenosynovitis, this is the normal, we can see this is the normal finger tendon depth. And here we can see tendon thickness is increased. And here we can see there is accumulation of fluid. And here this is displaceable, and this is synovium, we'll see later on. Okay. So, and this is synovial sheath. This is cross section of the finger tendon. And here we can see this is the synovial sheath, and here there is accumulation of fluid in the synovium sheath. So it is flexor tenosynovitis. So beginners should scan to and learn to know all extensor tendon which are nines and which are placed in 6 compartment, so that they are able to understand how tendons looks like. And it comes with the practice. Here one may find a lot of anisotropy, and they'll be able to learn what is anisotropy also. And this extensor tendon shows extensor tenosynovitis of 4th compartment, extensor digitum communis. And here we can see we have kept probe here, and we can see this is the biceps muscle, and there you can see there is effusion here and here. So this is bicipital tenosynovitis. Here we can also see biceps tendon is also thickened. So it is a case of biceps tendinitis, and also there is accumulation of some fluid. So also it's a case of biceps tenosynovitis. And in cross section, here we can see this biceps, its ligament is torn, transverse humeral ligament is torn here, and large hypoechoic area is there, which is collection of the fluid. So this is secondary to here. This is the area of subscapulis muscle, and this side supraspinatus. So this is complete rotator cuff here in this patient. And we know some tendon, those especially those who are doing surgery, Achilles is covered not by a tendon sheath but a paratendon. And paratendon, that glistening structure, that looks hyperechoic. We can see this structure, this is hyperechoic. This is the paratendon of this person. And this is normal, this is normal supraspinatus, this is biceps, this is in the transverse section, and this is in the longitudinal section. Classical parrot beak appearance can be seen. And here we can see in cross section, tendon is thick, very much thick, and there is a small area of this small hypoechoic area. This hypoechoic area is present. So this is thickness of the tendon. This is a case of tendinosis. This is in the cross section, and these 2 pictures in the longitudinal section. So we should know how tendinosis looks like. The first things, it will be thick, and it will be the heterogeneous. Ideally, it should be like hyperechoic, but it will be mixed with the hypoechoic structure, and cortex will be smooth always in case of tendinosis. And in tear, we can see like collection of fluid will see like hypoechoic area, and it mostly it will be well defined. and it will be homogeneous, and sometimes it may be associated with bony irregularity. Here we can see this is the insertional tear of the supraspinatus. So this shows bony irregularity. And here it shows cartilage interface sign. It should not be confused with the calcification. And these are cases of calcific tendinitis, and this calcific tendinitis sometimes may be better and easily find out in ultrasound than the MRI. And you can see in X-ray, this is barely visible. This calcification is easily visible, so there is no need of ultrasound is there. But if in case of early calcification, there is ultrasound has a very good role. And sorry, what happened? Yes. And here we can see this is a cross section of Achilles tendon. Here we can also see that there is hypoechoic area, tendon is thickened, and hypoechoic area hit, and it's a heterogeneous appearance. So it is a case of tendinosis of tendoachilles tendon. And here we can also see normal tendoachilles tendon is usually less than 0.5 centimeter. Here it is almost 0.9 centimeter. So this is a case of tendinosis. And here we can also see calcification at the insertion of the tendoachilles tendon. These are calcifications. And even we can also find out the tear of the common extensor tendon. So we can see this is the normal picture of common extensor tendon when probe is kept longitudinal to this. So this is the normal, this footprint is normal. This hyperechoic structure is the normal common extensor tendon. And here we can see in this structure is hypoechogenicity, especially. So this is a tear of extensor carpi brevis muscle. And even we can confirm it in both sections. This is transverse section. So in transverse section, all muscles even can be identified. This is the extensor. This muscle is extensor carpi radius longus. This is brevis. This is extensor digitorum communis, and this is extensor carpi ulnaris. And here we can see this hypoechoic structure is tear in the extensor carpi brevis muscle. So we can plan such tear, so we should not inject at least corticosteroid, which is the most common mistakes done by most of the clinician. In case of tear, we also inject corticosteroid, so it may result in more tear, so more disability. You can see how bursa looks like. Bursa is a small collection of fluid that is normal for the smoothing of the structure. Like it may be present in places of around the joint, around the tendon. So we can see this is the normal. Yeah, this is the normal subacromial subdeltoid bursa. Okay, this is the deltoid muscle, and this is the supraspinatus muscle. So in normal situation, it is very difficult to find out. And here we can see this bursal walls have thickened up, this white structure. So there is thickening of the bursal wall. Okay, and here we can see huge collection is present in subacromial subdeltoid bursa, and this is secondary to rotator cuff tear. Okay, and this space is post injection. And so various bursas, even small bursa can be found out, like even pre-Achilles bursa, large bursa, olecron bursa, all kind of bursa is patellar, suprapatellar bursa, infrapatellar bursa. All bursas are easily detectable with the help of musculoskeletal ultrasound. And Baker cyst, you can see this is the medial head of gastrocnemius, and this is semimembranosus tendon, and this area is of semimembranous medial gastrocnemius bursa. And here it is enlarged. We can see here this is enlarged. And it is communicating with the joint. This is bone. This hyperechoic structure is bone. It is communicating with the joint also. And here we can see aspiration of Baker cyst. And here we can see one patient comes with this severe acute leg pain. And here we can see this bursa is extended till almost the mid calf. And here we can see this is the gastrocnemius muscle, and its collection goes till almost mid calf. And in subcutaneous tissue, we can see this is thickening of the subcutaneous tissue, and this is subcutaneous fat, and this structure is dilated lymphatics. So if we are able to exclude the DVT, these patients can be easily managed conjunctively in the OPD itself. And if you see ganglion easily arise from like tendon sheaths, bones, joints, or ligaments. And it is, since it's a collection of fluid, so it looks hypoechoic. And this is ganglion present in the A2 pulley region. Yes. Similarly, various ganglion, like ganglion at the ankle, they may cause symptoms of tarsal tunnel syndrome. Ganglion at the wrist flexors cause symptoms of the carpal tunnel syndrome. So we will able to find out the ganglion, we will able to diagnose the ganglion, we will able to treat those symptomatic things very easily with the musculoskeletal ultrasound. And if you see here, sometimes we may confuse with these structures. Here it is acromion and it is humerus. Here we can see only deltoid is present when we have kept our probe at this place, at mid-deltoid region. Here we can see complete absence of the supraspinatus muscle. So we should not confuse, and we should clearly identify the structures always, so that this is skin, this is subcutaneous tissue, this is deltoid, and this is again supraspinatus is missing here due to complete tear of the supraspinatus muscle. Okay. And various fascia and ligaments can also be found, like diagnosed, its pathology is diagnosed with the help of musculoskeletal ultrasound. Most common fascia which we encounter in our practice is plantar fascia. Here we can see this is the calcaneum, and this is normal plantar fascia, hyperechoic lamellar structure, normal plantar fascia. And here we can see it is thickened, and there is increase in hypoechogenicity. So this is a case of plantar fasciosis. And this is normal plantar fascia in cross section when we have kept our probe like this, and this is, we can see this is increased thickness of the plantar fascia and also increased hypoechogenicity. Similarly, plantar fascia rupture, sometimes plantar fascia, plantar lipomatosis, these things can easily be diagnosed with the help of musculoskeletal ultrasound. And then comes to cartilage. In ultrasound, normal hyaline cartilage looks hypoechogenous, like black, like this. Here we can see this is the knee hyaline cartilage. We have kept our probe like this in the femoral trochlear region. So this is the normal hyaline cartilage of the muscle. And here we can see thinning of the cartilage in case of osteoarthritis. But fibrocartilage, like menisci, this is knee joint, this is femur, this is tibia, and this triangular structure is menisci, which looks hyperechoic. Okay. And this is posterior glenohumeral joint. So posterior meniscus, we can able to visualize the posterior meniscus, and this posterior meniscus is hyperechoic. And bone, when ultrasound hits any bone, it reflected back. So it make a hyperechoic image, very white, bright image. So this structure is a bone. This structure is a bone. But here we can see there is discontinuity in this bone. Here we can see. And here we can see a small collection of hypoechoic material. Okay. That is primarily osteoid of post-fracture. So we are able to diagnose the fracture with the help of musculoskeletal ultrasound as well. Although X-ray, basic X-ray is always like asked to be asked, because we can visualize the whole structure in 2 dimensions. And if there is any confusion, we can ask for the CT. But especially superficial bone, that like this is fibula, it's very well visualized with the ultrasound, and its fracture can also be diagnosed with the ultrasound. And especially in case of rib, like in X-ray, we miss rib fracture, but ultrasound will very easily pick up the rib fracture also. Okay. And here we can see this is great toe fracture. This is metatarsal, and these are phalangeal. You can see these are all fractures, comminuted fractures of the great toe. And similarly, in case of inflammatory arthritis, bony erosion is characteristics, and it is easily picked up by the ultrasound, but it should be confirmed in the both longitudinal axis as well as transverse axis. And we should always know the limitation. We will not always will not able to visualize the all erosion, because whatever comes in the path of the ultrasound wave, that erosion only we will able to identify. Like in posterior part of the bone where ultrasound wave is not reaching, will not able to visualize those erosions. And similarly, ultrasound is a very good modulator to visualize the basic pathologies of the bone for guided injections, etc. Here we can see this is the posterior aspect of the elbow joint. This is olecranon, this is humerus, and this is triceps muscle, and this and triceps muscle aponeurosis coming to form this triceps tendon. Okay. So this is normal elbow. And here we can see this fat pad of this posterior elbow joint is getting pushed superficially by this collection. So it may be a case of inflammation. And in case of inflammatory arthritis, early fluid accumulates in the radiocapitular joint here, this area. So this is the ultrasound scan of the anterior elbow. Okay. This is radius and this is capitulum. And here, this is this collection of the fluid in case of early rheumatoid arthritis. And this is, we all know, this is the suprapatellar recess. This is the suprapatellar recess or pouch of the normal knee joint. This is patella. This is quadriceps tendon. Okay, and these are fat pads. So this is normal. But again, we can see here in case of inflammation, collection, there is huge collection of fluid, and these are synovial folds. And in cross section, we can see this looks like front-like appearance, leafy appearance of this synovial folds. Okay. So synovitis and type of synovitis and grade of synovitis are easily diagnosed with the ultrasound, and it helps in the aspiration and other management. Okay. Similarly, all joints can be scanned. This is the normal hip joint. Here you can see this is the acetabular rim. Okay, this is the acetabular rim. This is the head of the femur. This is the head of the femur, and this is neck. neck of the femur. And joint capsule extends till the neck. So fluid usually collected in this area. Here we can see this fluid is collected in this area. So in case many spondyloarthropathy patients are on physical examination, like there will be terminal restriction or terminal pain, but when we scan the ultrasound, we may see effusion. So our like probability will conform into the various type of diagnosis like peripheral onset spondyloarthropathy and other things. And here this is the normal ankle joint. Okay, this is tibia, this is talus, and here we can see this is collection of fluid, and here we can see this is the synovial fold. This is in the longitudinal axis, and this is in the cross section. Here we can see dumbbell separate collection of this fluid muscle. We can see huge collections of fluid along with the synovitis in ankle joint. Okay. So coming to nerve. Similarly, we should know in nerve also similar to tendon, it will be similar to like appearance will be very similar to tendon, but myelin will be black and connective tissue part, all connective tissue part that will look white. Connective tissue part will look white. So it will like feel like it will like sieve-like appearance. This dotted sieve-like appearance. In tendon, it will be highly totally compacted, and here it will not that much this dot will not so much compacted. Okay. So in case of any swelling, this hypoechoic structure will increase and hyperechoic structure will decrease. So we'll able to diagnose nerve pathology and compression of nerve by the surrounding structure also. This is the basic carpal tunnel syndrome. Beginners should try to learn and scan the whole forearm area. Okay. This is nerves usually run in like in planes. This is the plane of the superficial and deep compartment. This is the superficial flexor digitorum superficialis compartment, and this is profundus compartment. Okay, and this is median nerve at this place. And here you can see this is the normal median nerve, and here you can see this is the enlarged median nerve. And anywhere all nerves can be identified. Here we can see this is the tibial nerve. This is common peroneal nerve, hyperechoic dotted structure. You can see this is hyperechoic dotted structure, just proximal to popliteal crease. And here you can see this is the common peroneal nerve. Again, we can see this is hypoechoic because it has been compressed at that site. Okay, so it has become hypoechoic. And in case of all Hansen's disease, most of the nerve will look swollen and increase in size, and it will be hypoechoic. And even a small nerve with the presently available ultrasound machine can also be diagnosed. Here we can see this is the hook of the hamate, and division of even ulnar nerve can be found. This is, you can see, this is deep division of the ulnar nerve. This is the superficial branch of the ulnar nerve. And here we can see this is ulnar nerve hydrodissection at Gans canal. Okay, here we can see this ulnar nerve at elbow. It's thick and hypoechoic in case of Hansen's disease. Here we can see how size is increased in case of Hansen's disease. So ultrasound also helps in aspiration and confirmation ke whether we can see this is huge collection of fluid. This is needle, And again, we have injected, this is the injected material, this is a steroid. Okay, it is mimic calcification, and this is, you can see this hole is the after full injection of the steroid. Okay, so where steroid has gone, whether it has gone in muscle or joint, we can able to detect that also. Okay, and various kind of even a small thing, glomus tumor, which are not visible. Here we can see this image has been taken from the internet. Patient is actual. We can see this is the nail plate. This is the nail plate. We have kept ultrasound probe like this, and this is the nail plate, and this is a small structure. This very small structure is glomus tumor. This is from the dorsal side, and this is from the palmar side. This is a small structure of the glomus tumor. So we can see nowadays eras ki machine should come to the patient. We should examine the patient bedside, and these portable machines usually doing and solving those things by answering a specific clinical question, and we can extend it as a part of clinical examination, and we always correlate between the image finding and like our clinical examination. So we should summarize why we should do ultrasound, because it's a real time, the most important. We can always see the dynamic examination, real time, real time things. Like we can see in this image. Sorry, window is not. In real time, it was. We can see in caudal epidural space. We can see the injected real time video whether it is going there. So we can always be. Yes, video is running. So ultrasound is real time. Okay, it is multiplanar. Although this multiplanar means, but since body has 3D structures, but with this ultrasound represents 2D images through the body, so that probe must be moved from one end to other end to visualize the whole getting picture of that 3D images. So assumption and visualization of 3D structure is very important while doing the ultrasound machine. And there is no radiation. It's not that expensive. It's widely available now, available in most of the clinical department. Okay, and always compare. We can always do the comparison, but we can always keep in mind that sometimes pathology may be bilateral also. And if with the 10 hertz, 10 megahertz linear frequency, we able to differentiate the structure 150 micron structure, and with MRI we are able to differentiate only 450 micron structure, megahertz structure. So we are better, like with linear probe, things are better characterized in the ultrasound than MRI. Thank you. Thank you very much.
Thank you, Dr. Rajkumar. Beautiful presentation. You have almost covered all part of the body, upper limb, lower limb, nerve, muscle, tendon, ligaments. It was really realistic presentation with addressing different pathologies and how to compare with the normal pathology, normal structure. So the basic thing is that for all young physiatrists, of course, I am not so expert in ultrasound, but still, whatever knowledge I have, I would suggest that all young physiatrists, whoever is interested to come into interventional physiatry, yes, ultrasound guided intervention is one of the bright future ahead. For that, we should very strong on basic anatomy. The basic thing is that what the mind knows that the eye says. Unless we are not thorough about the anatomy, the structures are although in front of us, well difficult to find it out. So this is mandatory. Nothing harm in that. Whenever we are going for any intervention or any examination, we should have a handout with us, or so many soft copies are also available. We can go with that. Plan your ultrasound program, prepare your list, and before going for ultrasound examination, go through your literature, your soft copies, your whatever soft copy books are available with you, go through that. Then you will able to find out the pathological structures, uh, whatever able to diagnose. So this is my suggestion for all young physiatrists. You know, a very good presentation. Let me see whatever the questions are there in the chat box. We'll go one by one.
Sir, Devendra sir, this side, Devendra.
Hello.
Sir. Hello.
Yes, 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 please.
Oh, sir, good evening, sir.
Good evening, good evening.
Sir, Dr. Askumar sir, very good presentation and very informative. And I am asking one question. There's a synovial hypertrophy and synovial, uh, uh, folding layer. Is there different things or some, both are these found in the osteoarthritis of the knee?
Yeah, in osteoarthritis, we may also find the synovial hypertrophy. Okay, first there is hyperplasia, then it become hypertrophy. All the synovium, like first one layer synovium. Suppose there is one layer of synovium, it becomes 8 to 10 layer. Then again this layer becomes hypertrophied, so it becomes very very thick, very very thick. Even you can also
is there
palpate.
is there any ultrasound screening is different or the same?
What ultrasound? Yeah, no.
Ultrasound picture
Ultrasound
is the
scanning is same. Ultrasound scanning is same. It is scanned in two scale. Gray scale, we can able to visualize the fluid, synovium thickening. Okay, and in like when we put the color, we can also see the increased flow in the synovium. That means the synovium is active. It has not become fibrotic. So active synovium needs treatment. Otherwise, it will joint will very easily damage.
sir.
If
How to
synovium is
differentiate
active,
it?
yeah.
Sir, one of the question other how to
Yes.
differentiate is a tendinitis and a tendinosis
Yes.
in the ultrasound images.
Yes. Like tendinitis, na. Like
Yes, sir.
sometimes both are mixed, but in tendinitis, tendon will be thickened. See, similar lamellar, I told you, compact lamellar structure will be there in case of
Okay,
tendinitis.
sir.
And in
Okay,
color,
sir.
it may take the color. But in case of tendinosis, tendon architecture will be lost. As you say, it will be heterogeneous appearance. That hyperechoic structure are converting into the hypoechoic structure.
Okay. Means some fibers are, some fibers are
Getting
tear.
degenerated, yeah.
Not
Some
a
fibers
complete
are
tear,
getting
but it's some fibers are
degenerated.
tear in the
Yep.
tendinosis.
That's why
Okay, sir.
I since it was first presentation on ultrasound, so I stick to very basic. If situation demand, people will be interested, we'll go one by one detailed, like area wise and intervention wise, detail wise. We can go to any extent.
Sir,
Yeah.
how to differentiate? Sir, how to differentiate the ACL structure in the ultrasound? How to approach actually?
This is not a part of like this presentation. I don't
Okay.
practice ACL, ठीक ना? But one of my colleague has done thesis on that also. So
Okay,
people
sir.
will see ACL, okay. People can see the ACL, okay. So they maybe it's not visualized properly, but they can screen the ACL tears on ultrasound also.
Okay, sir. Thank you, sir. Thank you.
Thank you,
Yeah,
you
there are
know already
questions also in the
all
chat
things.
box. There is questions in the chat box also. While scanning for plantar fasciitis, at what point relative to calcaneum do we measure the thickness? I mean, he is asking probably from insertion to up. At what point you should measure the thickness for plantar fascia?
Yes. Plantar fascia thickness at the where thickness is maximum. Like, let me. Why it is not going back? Screen. It has come to end. Okay. At the place of at the insertion, where the thickness is maximum, we'll practice these things. Lot of study says different things, but wherever at one point at the point of insertion where thickness is maximum, when probe is perpendicular to the calcaneum and thickness is maximum. Just stick to this two basic principle.
So it is measured at the insertion point to the calcaneum.
Yeah, at the insertion, definitely at the insertion. Slide is not getting back. I don't.
One question in the chat box: how can we register for musculoskeletal ultrasound, PCP and hurdle eligibility and process?
I don't have any idea. I am practicing.
I think there should not be any problem. As far as my practice in our institute is concerned, we apply to our CDM office, and yes, you are eligible. You can apply to your chief district medical officer of your district, and there are separate pro forma for that. Now it is online applications are also possible, but you have to give the undertaking and declaration that you are not going to do any screening for O&D, obstetrics and gynecology evaluation. That undertaking you have to give. So I don't think it is a problem. Initially we face the same problem, but afterwards we succeed to register ourselves. So that will not be a problem. You have to apply in the CDM office, Chief District Medical Officer office of your own district. So I think your tips for better visualization of needle while doing ultrasound guided intervention.
Tips of
better visualization of needle while doing USG guided intervention.
Needles should be kept as much parallel as possible in long axis.
Okay. What
okay, as angle increases, it may reflected wave may not come to the probe. But now there are various software which may like take up that also. Or like ecogenic needles are also there. But as much parallel, like in plane technique, you will try to keep the needle as much parallel as possible. You can heap up, like you can use your gel, ultrasound gel, to make it more parallel. Heaped up technique.
Someone asked, what do you see in case of chondromalacia patella?
Chondromalacia patella, definitely this is chondromalacia cartilage. So you will see the increased hypoecogenic structure. Hypoecogenicity will be increased. Okay, cartilage destruction is there now. So cartilage looks black.
Okay, thank you. So there are no more questions in the chat box. If there is no questions, then we can wind up the session. Kanu is visible. Do you want to say something, Kanu?
Yes, sir. I want to say
Yes,
it was
yes,
a very nice presentation by Dr. Kumar sir. He was the pioneer when I was in IGIMS doing PG. So very few people used to do the musculoskeletal ultrasound. And Dr. Kumar, when he would do, and we used to watch him. So we have learned the ultrasound basic principles from him. So I want to say regarding the registration of the ultrasound for institutional setting, it is different, and corporate and private practice, it is little bit different as I seen the corporate sector. I was in Indian panel also, and outside clinic also, in private practice also. So in Delhi, in Indian panel, whoever is using the ultrasound machine, they have to register themselves, be the PMR specialist or anesthesia or obstetric gynec people. So everyone has to put their name. If our name is not there in the list, he cannot use the ultrasound machine, even if he's not registered. So particular name has to be there in corporate setting. And in case of clinic or private setup, so you have to, you can register as a PMR specialist, but the condition is that you have to obtain a certificate from your institution where you have done your PG or fellowship or research, that you are trained in musculoskeletal ultrasound for the duration of 3 years or 1 year, that certificate you have to give to the authority. That is the thing. Then PMR people can use, no problem in that.
A good
That
thing.
I discussed with Dr. Davinder, who wanted to start a musculoskeletal ultrasound in a clinic. So we discussed. He's PMR and then pain fellow in pain medicine fellow from AIIMS Delhi. So he wanted to start a private clinic there. So it may be different from state to state. As health is a matter of state. It may
Right,
be
right,
different
right.
in West Bengal, maybe different
Yes,
in
yes, yes.
Delhi
Some states
or
they are very,
Odisha.
very flexible. Some states they are very rigid to provide a certificate. Yeah.
Yes, sir.
Right. Thank you, Karan, for your comments. And one thing I noticed today is that really our students and physiatrists are now much interested on intervention. Looking towards the attendance of this webinar, it has exceeded more than 95. So that shows the interest of the students. That shows the interest of young physiatrists, how much they are interested to go into the interventional physiatrist. So Dr. Rajkumar and other friends who are very expert in this interventional physiatry, they should come forward, train more and more people, more students, so that this will spread and our PMR friends will have developed their own identity in the society. Thank you very much, Dr. Rajkumar. As customary, I
sir.
must thank you very much. You accepted invitation and delivered a very good lecture in this webinar. At the same time, also, I must thank all the office bearers of IAPMR and the PR team of the IAPMR who was helping us providing this Zoom platform for conducting this webinar. And I must thank my PG students and all office bearers of Association of Physical Medicine Rehabilitation Odisha for supporting us conducting such type of webinar. I hope today's webinar is very much helpful for all young physiatrists. With this, I stay here with due permission. I declare the close of this webinar. Thank you very much.